Our next speaker is Neil Ampel. Neil is Professor Emeritus of Medicine and Immunobiology at the University of Arizona and a supplemental clinician in infectious disease at the Mayo Clinic in Arizona. Neil.
Thank you. So I want to again thank the organizers and particularly GR for asking me here today, and to Josh for a very nice overview of mycoses and of coccidioidomycosis. So I was given this task of describing to you human coccidioidomycosis in 15 minutes. And so I'm going to get right to it. A lot of this is based on my about 37 years in managing patients with this disease, and I'm going to sort of focus on where all these problems occur with clinical management. And GR is this. So many of us have been drawing these cartoons for the different dimorphics, and so I felt I had to have my own. And I think Josh has already intimated this. The fungus lives in the environment as a saprophyte, as a mold, and that's my backyard in Tucson, Arizona. And it grows there, and it grows up out of medium or out of the soil. And as Josh pointed out, you get interdigitating cells degenerate, and this allows the release of these spores into the air. We call these arthroconidia. And these can stay airborne for a long time, and stochastic events, which we don't really understand, will allow inhalation of these. And as few as one arthroconidium, at least experimentally, can cause infection. Then the organism enters a mammalian host, such as ourselves, can enter deep into the lung, and there it goes, this remarkable transformation that we call dimorphism. And I'm really happy that John Taylor is here today, because he's going to really expand on this. I think this is a really critical event for all the dimorphic fungi. There are genes that regulate this. This is very important to the fungus. But I'm going to talk about what the host does. So fungi, by their very nature, are foreign. They have foreign patterns. They have glucans. They have mannoses and chitins, and these are recognized as foreign. And so we have an innate immune response that then becomes adaptive. And the adaptive immune response in coccidioidomycosis is cellular immunity. And we show there what we get in a classic cellular immune response, and cocci is no different, is a necrotizing granuloma. That is, we have a center with detritus and a few fungi. Surrounding that, T cells, which are making cytokines such as interferon gamma and interleukin 10. And then surrounding that are B cells, likely making antibody. So that's the classic response. And associated with that, we can see on the X-ray, is often a mnemonic process. The fungus persists in that, and data have shown that if you biopsy those granuloma years and years later, there's live fungus, and our presumption is that fungus stays alive for the life of the host. That's what happens to most patients, but in a few patients, things don't go that way. Patients do what we call extrathoracic dissemination. The fungus shows up clinically outside the thoracic cavity, and that has been typically associated with a poor cellular immune response and generally occurs weeks to months after that initial infection. And this results in failure to control infection and often requires antifungal therapy and prolonged follow-up. So, as Josh intimated, what's the clinical expression? Well, 60% of individuals are asymptomatic. They're infected, they develop that cellular immune response, and that's it. 40% will develop the mnemonic syndrome. 3 or 4 of these will be 3 or 4% will be complicated, and 1% will develop extrathoracic dissemination. And I've purloined this from John Galgiani with one slight tweak, but I think it's a good way to think about this. Out of 100 infections, 60 individuals are going to be completely asymptomatic, and if we measure their cellular immune response, say by intradermal injection of an antigen, skin testing, or a cytokine release assay, it will be positive. 40 will have this pneumonia syndrome. 3 to 4 of those will have complications, but most will recover and remain immune. However, this small number with extrathoracic dissemination will come from either group. So you can have a completely asymptomatic individual disseminate later, or you can come from that group. So they come from both groups. So what's the potential impact? Well, 5% of a complication of an infection seems small. But let's do some numbers. For years, we have said there are 150,000 total infections. But in fact, the number may be quite high, much higher than that. In this abstract from the international meeting we had at Stanford in 2017, a group of collaborators suggested that the number is much higher, that it's 150,000 symptomatic infections a year. That would give us 375,000 infections, and then you can see the numbers. There might be 19,000 complicated cases and 3,700 disseminations, and we might not be picking those up. And then we have to be aware of the risk of severe disease. So certain groups are at particular risk. For example, those with defined underlying cellular immunodeficiency. Classic would be HIV-1 infection, not on appropriate antiretroviral therapy. But there are others, immune suppressive therapies, as Josh talked about, corticosteroids, anti-cytokine therapies. Other drugs, we discovered Janus kinase inhibitor, ruxolitinib, is an enormous risk for multi-site dissemination. Those receiving cancer chemotherapy. And more importantly, certain racial groups, and particularly those with African ancestry, appear to be at particular risk for getting severe and disseminated disease. And I want to really point out this abstract presented at our last meeting by Sarah Spenlove, a graduate student at UCLA, where she showed this is genetically driven because individuals with African genes, not defined by where they live or how they define themselves, are at that enormous risk. And a paper by Amy Sue also looked at patients with dissemination to try to identify where that problem might be. And it might be beta-glucan recognition through dectin-1, so part of that initial innate immune response. And finally, another group are pregnant women. So acquiring new infection during the second trimester of pregnancy and after can be a disaster, and we don't understand all the elements of why that occurs. So these are the clinical presentations I'm going to discuss, and I'll just get into them. So the first is asymptomatic or subclinical infection. We've said that's 60%. Patients get a robust cellular immune response, and this should, in most patients, result in lifelong immunity because the fungus persists, and that keeps reminding T-cell memory that it's there. And so I tell my patients, you've been naturally infected. In fact, I tell them now that they're native Arizonans because they have a little bit of Arizona in them. But occasionally, as I intimated, patients will disseminate some weeks or months later, and we don't understand that process. And some others, usually when they're on marked immunosuppression, may actually disseminate years later. But what about primary pulmonary infection? That's 40%. That presents with cough, chest pain, and fever. Well, this is frequently confused with community-acquired pneumonia. And this results in enormous delays in diagnosis, as the default in most urgent care and emergency rooms is to treat a bacterial community-acquired pneumonia. And Dr. Donovan wrote a great paper showing the cost of that, $600,000 for these patients coming back, getting multiple courses of antibiotics. And as Josh said, we have no point-of-care test now to diagnose cocci. Now, cocci does have some unique findings if you look for them, night sweats, fatigues, and rashes. But it also is complicated by these immunological events. Severe rashes, erythema nodosum, erythema multiforme, toxic erythroderma, Sweet syndrome, these can be debilitating. And if they're combined with desert rheumatism, which is a symmetric polyarthralgia, patients can be on their backs. And it doesn't help to say, well, this is a good immune response to that patient who can't work. And finally, most of these patients who get these also get profound fatigue, which is often associated with loss of exercise tolerance. And this can go on for months, on the average 4 months. So even having the simple primary pulmonary disease can result in having these immunological complications which result in significant morbidity. And then you can have complications. Most common is a nodule. If we see that original pneumonia and follow that to the nodule, everything's fine. But what if we just pick up a nodule? How do we know that's not a cancer? Well, let's do a PET scan, but it's not diagnostic and very costly. So let's follow that patient. So now we're doing sequential CT scans and follow-ups. We're still not sure. Let's do either an endobronchial or a percutaneous biopsy. That's all cost and repeated visits. Then some of these nodules turn into cavities. Many remain stable, but some don't. And we don't understand why. These will start growing, and they can become contaminated not only with growing mycelial form of coccidioides, but other fungi and sometimes bacteria. Occasionally, when we treat, these get smaller, but many of these require surgical resection, which again is quite an expense and problem. And finally, if things really go awry, if that cavity abuts the pleural cavity in a small number of cases, you can have a lung collapse, a pneumothorax, which is a surgical emergency. So now we'll move on to extrathoracic dissemination, which I've already indicated is far worse than these pulmonary diseases. And we'll talk about non-meningeal disease. As I've mentioned, this generally occurs within 6 months of initial infection, but it may occur much later when we treat patients with antifungals for primary disease. And John Galgiani and I reported this years ago, where we had patients where we treated for very prolonged periods for primary pulmonary disease, followed them, and literally years later, still disseminated. And I have seen this repeatedly in my clinical practice. So early treatment of coccidioidomycosis does not preclude that that patient may still disseminate. So you have to continue to follow a patient. What if the patient does develop dissemination? This almost always requires prolonged antifungal therapy and follow-up. And we simply don't understand the immunology about this. It makes no sense. The patient often has cleared their pulmonary disease and shows up with disease outside the thoracic cavity, often in one site, and when it recurs, that's where it recurs. I have no immunological explanation for that, so we need to do more work there. And finally, the worst disease, meningeal dissemination. This is a very subtle presentation. Often, again, the patient has not presented with primary disease, so we're unaware that they have coccidioidomycosis. And it is fatal if untreated, as Tom Vincent and John Galgiani have shown. Often these patients have preserved systemic cellular immunity, but clearly not in their meningeal space. Therapy for this is difficult and it's lifelong. And triazoles, which we use now, sometimes fail. Intrathecal amphotericin is a very difficult modality. And on top of that, we may successfully treat the patient and they still may develop hydrocephalus. And in coccidioidomycosis, in general, if you develop hydrocephalus, you are going to require a mechanical shunt. And again, neurosurgical procedures, follow-up, shunt dysfunction. So what's my conclusion? Well, the majority of individuals who acquire coccidioidal infection do well and develop lifelong immunity to further infection. There are some who will not. And these latter individuals may be at risk for prolonged illness with complications that almost always require continued and close clinical follow-up, antifungal therapy, and sometimes surgical intervention. Current therapy is frequently prolonged and associated with a high rate of relapse after discontinuation. So this is a daunting, problematic disease that we need to do better on. Thank you.
Thank you so much, Neil. I know that's certainly a challenge to give such a broad overview in only 15 minutes, and hats off for a job well done there.